start that now. Okay, now I'll share my screen. So, great. So all of you guys, can you see the slideshow? Great. So thank you guys for coming tonight. Let me just double check. I see the recording button is going. So I'll start off by introducing myself. So my name is Katie Season. I just got married this summer, so you may see my name in the, you may see my name out there as Katie McFadden. I tweet and I'm on social media at Brooklyn Grows, and I wear a lot of different hats in the birth world. So, and I'm kind of do like a longer introduction, but I am a midwife, a former labor delivery and NICU nurse, a lactation consultant, and I have a bunch of different ancillary certifications in maternal and infant care. And I was working in the neonatal intensive care unit at SUNY Downstate Medical Center in East Flatbush, Brooklyn, for 5 years while I was going to midwifery school at SUNY Downstate. And something important to know about the hospital where I'm working is that it was a segregated Black hospital where over 90% of the patients that I cared for were Black. So the first time I really, just admitting a couple of new folks. Thank you everyone who's just joining us. This session is being recorded, so we can make it available later. So if you don't want to be on the recording, feel free to turn your video off and text me any questions, but also feel free to leave your video on so I can see some facial expressions as I'm chatting through the night. Thank you everyone for coming out. I was just introducing myself and talking about, I was working as a NICU nurse at SUNY Downstate and working in the, while I was going to midwifery school, and that was the first time that I learned about racial health disparities in infant maternal health outcomes. So it was like a 1-hour lecture in my 3-year midwifery program that I first learned that Black babies in New York City were 3 times more likely to die before their first birthday than white babies. And when I first heard that, I was like, holy, I'll try to watch my language throughout, but maybe cussing, but essentially, holy shit, those aren't just some babies out there. Those aren't statistics. Black babies in New York City, those are the patients I'm caring for. So if Black babies are 3 times more likely to die, that means my patients are 3 times more likely to die before their first birthday. So it's super problematic that I didn't know that this disparity existed beforehand. It's super problematic that I can't describe what is causing this disparity exactly. And like, if I don't know and couldn't explain, who would? Because I'm in midwifery school working in a NICU. If I can't explain what's happening with this phenomenon, who is explaining this? Who is working on this issue? And kind of at the same time that I heard that Black babies were more likely to die, I also immediately started to wonder if understaffing at the hospital where I worked was somehow playing a role in that, because in the neonatal intensive care unit, when we don't have the correct number of staff, we're much more likely to have a medical error and much less likely to provide standard and appropriate medical care to the babies that we are caring for. And so where the I was wondering, like, I wonder if our infant mortality rate is higher because we're having more medical errors and giving worse care on understaffed shifts, and that because we only serve Black patients at this hospital would ripple out to create a population level health disparity. And so, kind of with that thought, when I graduated midwifery school in 2017, I decided to just stay in my nursing position part-time instead of looking for a midwifery job, because I knew something was wrong, but not what, and I did not want to take on like more power and authority within this system before I could exactly, put my finger on how it was hurting the people who I certainly thought I was helping by being a nurse, by providing care. And so my thought was like, let me just chill here, learn more about these issues, and see what kind of effect I can have advocating as a nurse. And so I started asking questions like this from my bosses of like, do you think understaffing could be affecting our overall outcomes? And their response to me is, what understaffing? We don't have understaffing. And I was like, okay, well, we definitely do. So let me start making a written record of when we're understaffed and how that negatively impacts care. And at the same time, I went and did doula training with Ancient Song Doula Services and started getting involved in the community efforts that were already out there that were working on and addressing Black maternal health. My scheme coming out of midwifery school was to create a written record of safety issues and to see what I could do about it. So I write the first email that to start off this strategy, explaining to my boss that we're understaffed, here are the things I couldn't do, when are we going to get more staff? And less than 24 hours later, we had a maternal death, a preventable maternal death. And so for me, like I was interacting with the mother who died just hours before she died. She had twins who were being cared for in our NICU. She was visiting them and had told us that she wasn't feeling well and wanted to go back to her room. We had, I think, 13 babies in the nursery that day with 2 nurses. So it wasn't safe for either of us to bring her back to the labor delivery unit where her nurse and her care team was, to monitor her. So we kept calling transport to say like, hi, we have a mom here who wants to go back. Like, when are we going to see you guys? And we called transport like 2 or 3 times. And she probably waited for almost an hour and a half, 2 hours in the NICU after she said she wasn't feeling well, before she was able to be transported back to her floor where she was getting monitoring. And then once we started hearing the emergency codes on the loudspeaker, we heard the code was called 9 times. And just like for folks who don't work in hospitals and who may not be used to hospital culture, like 9 times is a lot of times to hear a code for one person. The whole point of a code is you call it once and everybody in the hospital who would be helpful to respond to that situation comes right away. So if 40 minutes after the first code, they're asking for the anesthesiologist for the 3rd time, clearly the medical personnel who should have responded to that emergency situation and been available to help save her life didn't show up. And so like, when we were hearing these codes, like I was looking at my coworkers, we were saying to each other, like, seriously, like, what is going on? Anybody in this hospital who could potentially be helpful should already be there by now. Like, what is happening here? And then we learned shortly after that it was the mother that we had been struggling to try and get back to her unit. That is who we had heard dying over the loudspeaker. So my strategy for advocating about safe staffing became much more focused and much more aggressive with how I was interacting with the hospital administration. And because I thought that was for sure going to be the wake up call we needed to fix the understaffing, and it wasn't. And I kept coming back to work shifts and it's not like we should have had, we were 1 or 2 nurses short and we were just a little busy. It's like we should have had 15 nurses in the NICU and we had 7 instead. Like, it was just incredibly dangerous, and somebody had already just died of preventable causes that had to do with understaffing. So I started writing emails up the chain of command at the hospital, essentially to say, what the fuck? Don't you know somebody just died from this? What are we doing? When can we expect more staff? When is this going to become more safe? And I start writing things, it's just a matter of time before something like this happens. We never get more staff. And on November 28th, 2017, another woman died in our hospital of preventable causes shortly after having a cesarean section. So what I didn't realize at the time, but what I have juxtaposed in these slides, is that as I was sending these angry emails to my bosses, asking what was going on and when we could expect more staff, the headlines in the news was that Cuomo was holding up aid. Just to be clear about how egregious this was, it wasn't like we're going to cut aid in the future. It was that aid that was already earmarked for the hospital from the federal government was coming to us in 2017, and the same earmark funds that was coming to us in 2018 was going to be a little bit less. So we knew that, and the hospital was planning for the 2017 money to be one thing and the 2018 money to be less, because we knew that that's what was happening from the federal government coming down to the state-run hospital. What Cuomo chose to do was to hold the money in 2017 to make it so that we were having 2018 levels of funding in 2017, which was several tens of millions of dollars of funding that we had already spent, that we were already planning to use, that he was like, you know what? I want you guys to get used to what it will be like to have less money in the future. So I'm just going to hold on to this federal funding that really shouldn't have to go through Albany anyway. I'm just going to hold on to it for myself so you guys can get used to what austerity measures feel like. So as I was sending emails to my bosses being like, where is the staff? Why is this so dangerous? There's a lot of things that the administration at the hospital, I argue, could have done differently to improve patient safety, but hiring more nurses really isn't one of them, because unless I believe my bosses when they told me that there was not money in the budget to fix the staffing problems, because that was what was in the news, and our union leaders were saying, because that was what was happening on a policy level, was literally money that we had budgeted to spend on care was being stolen from us and left us in a position where not only could we not meet our current needs, but we couldn't prepare or change anything going forward when it was clear that our patients were experiencing really dramatic safety issues. So beyond understaffing, so kind of in the wake of these 2 maternal deaths, a ProPublica article came out about them, and I think word kind of got out to the community that 2 people had just died, and fewer people, a lot of people chose to give birth elsewhere in 2018, 2019, and our census went down. So it wasn't quite as bad with the patient to nurse ratio. But what I realized in 2008, going from 17 into 2018, as I was taking all of these self-study courses to become a neonatal developmental care specialist and to become a lactation consultant, was like, oh, even on a shift where we have appropriate nurse to patient ratio and staffing, we're missing 12 different specialties. So it kind of doesn't matter if everybody who works there is there that day and doing their job well. The fact that 12 positions are just missing and those specialists are just missing means that the overall level of care that we are able to provide our patients is hugely categorically different from the care that Mount Sinai, that NYP, that NYU are able to provide their patients in their NICUs. And this, in large part, explains the racial disparities that we see, certainly in NICU outcomes. Like essentially 100% of racial disparities in NICU outcomes have to do with the care that's provided in the NICU. Like NICU patients can't be non-compliant. Like once they're born and they're with us, it's pretty much us who determines their entire environment. And so, so I realized, oh, even on a good day when staffing is appropriate, staffing still isn't appropriate because we're missing all of these specialties. Why are we missing these specialties? The same reason why we didn't have enough nurses. A lot of these people either used to work for the hospital and quit during a hiring freeze, and so were never replaced. Or NICUs have only existed since the 1960s. So it's still a pretty new area of medicine. And we've made a lot of discoveries in the last 20, 30 years of how to improve NICU care, except for we've made zero investment in the last 20 or 30 years into the NICUs at publicly serving hospitals. And so some of the positions are missing just because we didn't know 30 years ago that a NICU should have that position. And in the intervening time, we've never had a budget that enabled us to keep up with what research and with what research was showing maximizes and improves patient outcomes. So that is, all of that was just to introduce myself, essentially to say like, hi, this is how I came to work on the New York Health Act, is that we're gonna, essentially the rest of the presentation, or a lot of the rest of the presentation is gonna be on why the hospital didn't have any money and the health policies that led to us being chronically underfunded. But like the too long didn't read explanation is they'll all be solved by the New York Health Act if and when it passes. And so as I was, really trying to see this through, Black Lives Matter. It mattered that a mother of 6 died on an understaffed shift, and we can't just like shrug and walk away and hope it doesn't happen again. It is happening again. It has happened again. So I really wanted to see this through of like, well, what policies could have prevented that and would prevent that in the future. And yeah, New York Health Act. So I wanted to, so some of you may be wondering like, who is Katie and why is she hosting a teach-in? And like, so I am, I'm a whistleblower nurse. That is, I have a Zoom account and a Canva account. I don't get paid to do any of the activism work that I pursue. I just got really involved with the campaign for New York Health, and I'm now at the point where I'm probably one of the 10 or 15 people in this state that like understand the ins and outs of the bills pretty well. And seeing how much this is going to improve not only the situation that I experienced, like that brought me into this with maternal mortality, but how much it can stand to improve the lives of birthing people in general. I really wanted to engage other birth workers and help get other birth workers involved so that we know first what the bill is, so we can help get the bill passed, and also so we can help improve the bill for birthing people. So kind of the I have another slide that talks about like our objectives for tonight, but the overall objectives of having like the two-part teach-in is essentially tonight and next week. Is like tonight is a lot of like the why and how, and next week is going to be much more of the what, like the actual text of the bill. But the hope is that after these two teach-ins, and we have a bunch of birth workers who kind of understand the basics and are on the same page about the basics, that we can meet together in working groups and come up with with some recommendations of how to actually add amendments to the bill to change and improve it for birthing people. The New York Health Act covers long-term care, and it hasn't always. A couple of years ago, long-term care was not included, and the disability community got involved and was like, hey, we actually really need long-term care from our health insurance. Can we make sure we get that in the bill? And they worked together with legislators and got it in the bill. And now the bill is much better for people with disabilities. So in the same way, I'm really hoping to engage birth workers from kind of all disciplines, so that we can give our input on how to improve this bill for birthing people. The legislators who are proponents of the New York Health Act are really strong, progressive, really great legislators who want to do things well for birthing people. So like they essentially are just waiting for our recommendations. So we have to, they're like, oh yeah, of course we want to know what midwives and doulas think of how to improve this. So that means we just need to be on the same page to be able to tell them and to give them some well thought out recommendations of how to improve it. So, and then the aspiration, essentially, like just generally as I've been organizing, it's a lot of learning as I go, organizing to address the issues at SUNY Downstate and the issues that are facing the birth world more generally. A vision I have for that, or what I really hope will come from that, is a network of reproductive justice minded folks throughout New York who are connected, who are politically involved and connected to one another, so that we can advance legislation that already exists that will help improve the lives of birthing people, but also so that we can work together to create our own legislation and get it passed. So like something like a parental leave bill that, when you have a baby, the state sends you a check for $4,000 a month for 2 years so you can actually stay at home with your baby and take care of them. Like, what a crazy idea. We have the money in the state to do that. Like, there are enough rich people in New York. We could tax them and fund a program like that. We just need to be working all together across the state to create the political power to be able to actually put that on paper and get it passed. So I'm gonna send in the chat box a link to a form that is titled Movement to Birth Liberation. So that is my aspirational title of this network, is that we will be a movement of people working to birth a liberated society. So please, please fill that out and make sure you put your full street address. And what that allows me to do is see who your state representatives are and connect you to other people in that same district, so that if and when there's a strategic way for your representatives to be supporting a reproductive justice bill, we can let you essentially get in touch with you, let you know, and do that in district organizing, so that politician by politician in New York, we get everybody on the same page and we move move towards a more just and more liberated world. So yeah, so please folks fill that out. And let me, yeah. So, and then the objectives for tonight, now that it's already half over, I guess a lot of the objective tonight was just to get to say hi and get to know you and introduce the idea and the concept of what we're doing. But for the rest of the night, I'll explain briefly what is the New York Health Act, why it's important to reproductive justice and reducing health disparities, and how you can get involved to pass the New York Health Act. Also, stop. Not any questions? Things folks want to, feel free to unmute yourself and jump in if something's pressing and you don't and it doesn't seem like I'm going to get to it tonight. So just really briefly, the New York Health Act is essentially a state level improved Medicare-for-All program that would create the New York Health Plan, which would provide universal, guaranteed, equitable health coverage for every New Yorker, every person who lives in New York State or works in New York State, regardless of immigration status. It will cover everybody. And it covers essentially everything. It covers dental, vision, mental health, prescription drugs, medical supplies, long-term care, hospitalization, specialists. It essentially, like, what a crazy idea, takes the finance, the profit and the finance out of things that affect your day-to-day well-being and body. How much will the New York Health Act cost depends on how much you earn, because or like how much it costs you as an individual will depend on how much you earn, because it is paid through a graduated taxes. So the exact tax system isn't determined in the plan. That's going to be worked out in the first couple of years. But most of the ones that have been proposed, essentially you don't even start paying taxes until you make $25,000 a year. And then when you do, it's a very reasonable, I think if you make $26,000 a year, you pay $90 for the entire year in taxes towards your health care. So it's a very reasonable tax that increases with your income, so that your contribution to the health system is tagged with your ability to contribute to a health system, and not tagged to how sick you are and how frequently you need to use the health system, which is currently how we fund our health, how we fund healthcare. And over 90% of New Yorkers are projected to pay less in taxes towards the New York Health Act than they are currently paying on their medical expenses. So if you're like, oh, that was really interesting, and you went through that really quickly, and I have a lot more questions about the specifics of the bill, that's why I need a two-part teach-in. So come back next week, and that's when we're going to get into like all of the nitty-gritty of the bill. And yeah, all the nitty gritty of the bill, and where I'll start explaining like where I see opportunities for us to improve it for birthing people. But tonight I just wanted to make sure like we were all on the same page, and I had something I could point to that explained like the why it was important. And then I keep saying next week. Next week is the day after the election. So like, just let's put an asterisk by that, because if we need to be protesting in the street the day after the election, I will be out protesting in the street and not hosting teach-ins. So depending on how things go with the election, maybe we're meeting next week, maybe in the coming weeks. But either way, there'll definitely be a second teach-in. Just keep your eyes open for. We'll see how things go. So I'm going to try and wrap up all my slides by 8 to make sure we have time, and I'm happy to stay on however long for Q&A. But again, please interrupt me if there's something you want to add or any questions you have. So I just wanted to touch a little more or to revisit, like, why is the New York Health Act important for reproductive justice and important for reducing racial health disparities? Well, reproductive justice, what is reproductive justice? I think the shortest way to describe it is a framework that describes the right to have, to not have children if you don't want them, but if you do want them, reproductive justice includes the right to be able to have children and raise them in a safe and healthy environment. And it is a framework that originated by Black radical feminists in the 1990s, kind of as a response to what was often, the reproductive rights movement that was often very narrowly focused on abortion rights, which are incredibly important. Abortion is healthcare. But it's somewhat perverse, but it's somewhat perverse to only focus on abortion rights when there are lots of people who would like to have children but are not able to because there is not a safe and healthy environment to be able to raise them in, or because other things are impinging on their ability to reproduce. So reproductive justice isn't just the ability to end a pregnancy that you don't want, but it's the ability to have a pregnancy that you do want, and to have a pregnancy safely. So why is the New York Health Act and universal health care really important for reproductive justice is, just generally, like, you can't raise your kid, like, without universal health care, you have to be rich to be able to raise your kids in a safe and healthy environment, because you have to be rich or employed in a certain sector to have the health insurance that is going to cover your own health to keep you healthy to raise your children, and that's going to cover the health of your children. So I think, like, just generally it makes sense, like, we have to be a society that provides for people's healthcare needs if we want to be a society that allows people to reproduce as they see fit for their own selves. Some other specific examples are, or ways it helps, is that like, currently a lot of people get their health insurance through their spouse's employer, and that puts pregnant people in an incredibly dangerous position if they're in an abusive relationship, where they may have to make a decision of the health of their pregnancy by staying on health insurance versus the health of their pregnancy by staying with an abuser. So by giving guaranteed health insurance, we take away incentives, or perverse incentives, to stay in relationships, or that limits people's freedom of who they should be with and who they should be with. As far as most people get their health insurance now through employment, but that takes away the reproductive right of raising your own children in a way that is, not there. If you want to raise your children without working in a job that offers insurance, you don't have, like, essentially that option is being taken away from people because we've tied employment to insurance. So folks can't really choose to stay, or may not be able to choose to stay home to raise their children, because they are forced to work to as a way to maintain access to health care. Also, right now, a lot of people don't qualify for public forms of insurance until they get pregnant. And so a huge barrier to getting early prenatal care or preconception care, if you have chronic health issues that you want to optimize before getting pregnant, you may not have that option because you may not even qualify to get the insurance to start seeing somebody until you're already pregnant. And then by the time, between the time you get your positive pregnancy test and are able to do all the paperwork to get on your insurance and then find somebody who takes that insurance, you may already be well into your second trimester and have lost the ability to optimize the health of the pregnancy by receiving early prenatal care, and may have lost other abilities to make decisions about your pregnancy that need to be made in the beginning of the pregnancy because you didn't have access. It removes barriers for switching care. If there's a, right now, if you don't trust your provider, if you realize at some point in the pregnancy that you're not satisfied with the care you're receiving, it can be very difficult to find somebody that accepts your insurance and switch midway through. So it removes removes barriers for people seeing the providers who they really want to see. And I think maybe the most important thing that going to the New York Health Plan would do is it doesn't, like, nowhere in the law will it guarantee that everything's going to work out okay, but it does consolidate who we would need to who we would go to when something is broken to get it fixed. Which is to say, like, right now, if one insurance company is not reimbursing a home birth midwife, it's really difficult. Like, a home birth midwife can't call all of her past clients and say, call this insurance company, because all of her past clients may be on 10 different insurance companies. So they can't all call to the same place to demand some kind of change. If everyone's on the New York Health Act and it doesn't pay enough for home birth, well, now we have one entity to lobby to improve the care. And so it makes it, it puts more power, it puts power back in the patient's hands, or collective power back in the patient's hand, by giving us one entity to focus our attention on if and when things need to change. All of those things being said, are there things I've forgotten that you're like, oh yeah, when we have single payer healthcare, this thing will be different and that will make things better? Please unmute yourself and share. I'm sure I've forgotten lots of great things. Go for it, Fred.
As I'm not qualified in any way in terms of being a healthcare provider, and particularly in birthing, but when we first started having children, which was in the late 60s, we lost our first, I want to talk about prescription prices and drug prices. That's what I want to get to. Lost the first baby at 6 months, born at 6 months, lived 8 hours. In the second pregnancy, there was some prescription stuff that was prescribed because there was some known issues that would increase the probability of live birth. Mm-hmm. And one of the things that the New York Health Act does is it makes prescriptions priced on a level of Canada. And if, of course, as you said before, you don't have to pay, there's no copay, there's no deductible, so prescriptions just come. I'm curious about, and I'm not knowledgeable about today's pharmaceutical stuff, but I would guess that having access to pharmaceutical things, either to make pregnancy more likely to complete or other kinds of things around pregnancy, would be a major issue.
Absolutely. Absolutely. I'm thinking off the top of my head of a pretty expensive progesterone shots that can, now I'm hesitant to say the next thing because I think the data, there's a bit of a question mark of if they actually help. But when we thought they helped prevent prematurity, they are also very expensive. And that was a barrier for people receiving what we thought was a useful therapy for reducing preterm birth. So I'll go on to my next slide, but if you have other things, please feel free to jump in. So that I was thinking, the last slide was thinking mostly of birthing people. For birth workers, how does the New York Health Act improve our lives? Well, first off, I think most importantly is the philosophical thing, is that it ends the state-sponsored hierarchical valuing of our patients' lives that currently tells us when we have a privately insured client, it's worth $300 to spend a half hour with them. And when we have a client on public insurance, it's worth $60 to spend a half hour with them. Like, when we have varying reimbursement rates, or when there are such disparities in the reimbursement rates, I think it is wild to not think that providers would internalize that and differ the care that they provide based off of how much they know they're being reimbursed of who they're seeing. and if that, I'll talk a little bit more about that in a second. But also it reduces administrative costs, like just I know home birth midwives spend a lot of time working with their billers and trying to troubleshoot reimbursement issues, um, and trying to like help their clients navigate insurance issues. None of that will be an issue anymore. We can actually like focus on the health of the patients who we're working with instead of all of the administrative things that go around it. It promotes entrepreneurship and autonomy. I think this is super important, particularly for doulas, a lot of whom, you know, work independently. And it's very difficult to make enough money currently as a doula to also pay out of pocket what can be exorbitant prices for your health insurance. A lot of doulas keep second jobs just to keep the health insurance at their job, and then do dueling in, you know, kind of try to fit that in between. If health insurance is guaranteed, I think it would really open the door for people to start their own businesses, to invest in their birth work the way that they want to, because because they now have that freedom. And then lastly, like, again, if the unified entity to lobby, I think is really one of the most important things from like a professional standpoint, where like if the reimbursement rates aren't high enough to support a sustainable home birth business, well then let's go to our state senators and let's go to our elected representatives who are accountable to us and who know we can vote them out if we don't like what they do, and say, hey, raise the reimbursement rate, and make home birth midwifery possible. And we are able to focus our energy on one entity in a way that we cannot right now because of how diffuse things are with insurance companies. So so that's how I see the New York Health Act really being a huge step in the right direction for reproductive justice. As far as racial health disparities, I'm absolutely going to go over 8 p.m. to finish these slides, but I hope you guys all stick with me because it's interesting. It's interesting enough that I don't want to skip over any of them. So I think before like talking about racial health disparities, I think it's really important to establish that it is racism and not race that causes racial health disparities, which is to say that there is nothing about the biology or the genetics of people with African ancestry that would make them more likely to have conditions that would lead them to dying in childbirth or to die before their first birthday. There's no genetic susceptibility to the things that are making folks die. There's not a problem with so again, essentially race is a social construct and not a biological construct. And so when we see racial health disparities, that tells us there is something really wrong with the society, not the biology. And I say that like it's racism, not race, that causes racial health disparities. And so how does the New York Health Act help reduce racism and therefore reduce racial health disparities? Well, because private public health insurance is structural racism. And so we see that and how it plays out currently, but even the origins of private public health insurance really are rooted in American anti-Black racism. So it was in the 1960s when many other industrialized nations were developing their nationalized health systems. That was the same conversation in the United States was, yeah, let's develop a nationalized health system. But the conversation about developing a nationalized health system happening in the 60s was happening at the same time that conversations about desegregation were going on. And so the American Medical Association, which was officially segregated white into the early 70s, The first time they collected dues from their individual members was in the 1960s to fund a lobbying effort against nationalized health insurance, essentially because white doctors realized, oh, if we go to nationalized health insurance at the same time we're desegregating everything, we'll have to take care of Black people. And so if instead we push for privatized health insurance and for people to get health insurance through their employment, well, then we can keep just providing healthcare to the folks that we want to provide healthcare to, because we'll just choose to only see people under the insurance companies that insure people who work for companies that are officially segregated, because it's still the 1960s in America. So it really, like, there are more white people on Medicaid than Black people overall. Like, public insurance isn't an inherent, like, isn't exactly racialized issue. They're not a one-for-one thing, but public insurance is racialized in this way, or, you know, public insurance is racialized both in the fact that Black people are disproportionately represented on who uses public insurance, and because there was a racist reason to begin with to create this system that creates literally separate and unequal ways of providing healthcare coverage. Providing healthcare coverage to people. So, like, just based off this principle alone, we should go to single payer, because it wasn't a good reason to begin with why we didn't choose single payer. Now we all know that that's the reason. Let's go to single payer. But how this connects to the issue that I started off talking about and the maternal deaths at my hospital is, this is why the hospital didn't have any money, is because of the structural racism that is private public health insurance. So Medicaid, which 2/3 of Black birthing people on New York use Medicaid, reimburses at half of the rate that private insurance reimburses for obstetric care. So if you're a hospital that serves predominantly people on public insurance, you're taking in half as much money as a hospital that's serving people who are predominantly on private insurance. And it's not like private insurance are really like paying above and beyond what it costs to take care of people. They're just paying at cost. So if public insurance is paying half of that, that means that public insurance literally just doesn't match the cost of the lights and the Band-Aids and the medication and what it actually costs to provide care. And so if you are a hospital that serves a disproportionate share of people on public insurance, you're not going to have enough money to operate. And the fact that that is true is like tacitly admitted to within the own legislation, because within Medicaid is, within the Medicaid program is a separate pool of money called disproportionate share hospital pay, or the indigent care pool, or disproportionate share hospital payments. And they are payments that are specifically meant to go to hospitals that serve a disproportionate share of people on Medicaid to make up for the fact that the reimbursement rate is so low. So the first level, the fact that private health insurance is inequitable, that's inequitable everywhere. But in New York, it is even more inequitable because the mechanism that was supposed to make it more equitable, we actually have perverted through, I believe, government corruption, so that the money that is intended for the public hospitals actually mostly goes to the private hospitals in New York. So with disproportionate share hospital payments, this is the federal funding I mentioned before that we get from that DC sends to Albany, and Albany is supposed to distribute to various hospitals. And in every other state, they do it by who needs that money. In New York, they put that money into two separate pools, one for the private hospitals to divide into and one for the public hospitals to divide into. And you can see here, the one for the private hospitals is $1 billion, and for the public hospitals, only $100 million. And if you're thinking, well, that's weird because don't the public hospitals serve way more people on public insurance? Absolutely they do. And when what this graph represents, these blue bars is how much money the hospitals are paying on un and underinsured care, and the orange dots show how much money they actually got back from Albany. So what you can see is that the public hospitals are racking up tens of millions of dollars of debt every year, while the private hospitals are getting millions of dollars more than what they spent of just free money. Free money. So in 2015, 80% Black serving Kings County lost $80 million, while New York Presbyterian, which actively segregates their patient population based off of insurance status, which because of the disproportionate because of who uses what insurance status, if you segregate against insurance, you're causing de facto racial segregation. So the same year that a Black serving hospital lost $80 million, another hospital that actively practices racial segregation got $17 million more than what they spent. So when I first read these reports that explained all of this, I was like, holy shit, like, I guess I should get in touch with health policy experts and like the folks who wrote this report. And so we can come up with a better formula of distributing the disproportionate share hospital payments to make sure it actually goes to the hospitals that need it. And then I was like, oh, wait, I should just become an activist for the New York Health Act, because if we don't have private and public insurance anymore, then we don't have these weird loophole, then we don't have an inequitable system that we need to use further inequitable mechanisms to try and adjust. We can just go straight to an equitable system. So that's, so yeah, so the kind of I guess why I stand so hard for the New York Health Act is not only does it solve the general injustice of private public health insurance, but it's also the easiest and quickest way to address the really blatant injustice of New York Presbyterian and Jacobi seeing the same amount of uninsured patients and New York Presbyterian getting paid $41 million more to do it. So maybe I did. Okay, so so the when I first learned about disparities, I immediately wondered how, like, I didn't think if, I wondered how the hospital where I worked was complicit in causing those disparities. And as I learned more, I guess the more I learned about it, the more I realized that that was a great suspicion to have, because the research shows us that about half of the racial health disparities in New York City have to do with the lower quality of care provided at a concentrated set of minority serving hospitals. So these are two studies that Dr. Howell, who used to work at Mount Sinai and recently moved to UPenn, did. And in 2016, she found that if Black birthing people were giving birth or going to if Black birthing people were going to hospitals that were as safe as the hospitals that white birthing people were going to, on average, the difference in severe maternal morbidity rate would drop by 47.7%. So that's half of the problem, is a concentrated set of more dangerous hospitals. And the Howell's research doesn't tell us, the hospitals are anonymized in her research. But in other areas, you can find the severe maternal morbidity rate by hospital. And what you see in front of you is a graphic that I've made that has the 10 hospitals in Brooklyn listed from safest to most dangerous by their severe maternal morbidity rate. And mapped over, and mapped on and put over a map that shows the racial and ethnic distribution throughout Brooklyn. And what you can see is that the 3 most dangerous hospitals are all right in the center of segregated Black Brooklyn. And they're not more dangerous by a little bit, they're more dangerous by quite a lot. So the severe maternal morbidity rate at Maimonides is 1.2%, and it's 9 at SUNY Downstate. So it's 8 to 9 times worse at the hospital where I worked than a hospital less than 10 miles away. And so, and this, so the Dr. Howe's research doesn't say why the hospitals are providing worse care. You know, she says the problem is the hospitals. Who knows why the hospitals aren't providing good care? Well, these are the dots that that I hope my activism work connects for folks, is like, well, hey, the hospitals that are providing worse care are all the same hospitals whose budgets have been viciously cut year after year after year and have not been able to keep up on providing safe and standard medical treatment to their patients. So if we want to reduce disparities, reduce disparities in health outcomes, we have to reduce the disparities in health inputs and how we invest in the institutions that safeguard people's health. So yeah, and you can just, the next slide show, this is the, I already explained that map, but this map shows the colors show the infant mortality rate throughout Brooklyn, and you can see that the neighborhoods that have the highest infant mortality rate also feed into the most dangerous hospitals. So I have a couple more slides, but they're all essentially, if you're wondering, well, the safe hospitals and dangerous hospitals are very close to one another. Why don't people just go to the safer hospitals? And that would be because of the insurance discrimination that all 5 of the private hospital systems in New York City regularly practice. And what that looks like often is calling, if you call Mount Sinai, NYU, NYP, Montefiore, Northwell Health, and you say that you are on private insurance, they will set you up with a full, attending physician, faculty, professor within their institution. And if you call and say that you are on Medicaid, they either say, oh, sorry, none of our providers are accepting that insurance at that time or have any openings at that time. Or they'll send you to a student-run clinic where the quality of care you get is, night and day difference, because instead of seeing a doctor who's established in their practice, they're seeing a doctor who's training and rotates through month after month. So there's no consistency in care, consistency in the care that you're receiving. So again, like the mechanism that allows all of this malfeasance is the separation between private and public health insurance. We go to the New York Health Act, and it solves, it doesn't solve racism, but it solves this form of structural racism. And I think sets us up, puts us in a much better position to attack all of the other forms of racism that, I am very careful that I talk about this is going to reduce racial health disparities, not eliminate them, but it will put us in a place where we can tackle the, I think it's really, I don't know how to change, racism that lives in people's hearts, but I do know that if there aren't enough nurses at a hospital, how to hire more nurses. So let's fix the easier things that are out there to fix now. And so we can continue to work on the other things that are causing racial health disparities going forward. So, okay, so New York Health Act. We talked a little bit about what it is. Where are we at now, and why did I post teach-ins the same week of the election? Is because we are actually pretty close to maybe being able to pass the New York Health Act. So up until, there are 63 state senators in New York, and for the last 2 years, 31 of the 63 state senators have been co-sponsors of the New York Health Act. And co-sponsor is essentially a way to vote yes on a bill before it comes up for a vote. You know, it's a way to put your name on the bill, to publicly show support, so that if we got 32 co-sponsors on the bill, we know it will pass, because that's how many votes we would need for it to pass in the Senate. So for the last 2 years, the main strategy, we have 31 co-sponsors, we have 40 Democrats in the state Senate. So for the last 2 years, a lot of the strategy to pass the New York Health Act has been to put pressure on the 9 Democratic state senators who are not yet in support, to try and get them to sign on. With the election coming up, it presents a really exciting new way for us to build support, and that is by electing people. You know, if we can't change people's minds who are already in office, we can put people in office who we already know are in support of the New York Health Act. So something I've been putting a lot of work on lately is working with the campaign to identify where are those strategic state Senate races, so that we can build the support we need to pass the New York Health Act. So in a worst case scenario, there are 4 co-sponsors of the New York Health Act that won pretty narrowly in 2018. So in a worst case scenario, we could lose support for the New York Health Act. So I've been, we have a slide to send support to these general campaigns, and to keep these folks in office. And then something that's super exciting are all of these Senate districts that have viable Democratic state Senate nominees that could flip from seats that are currently held by Republicans, which no Republican has supported the New York Health Act. So I think it's pretty safe to say we won't be able to flip or pressure Republican senators to support it, but we can unseat them. So these are 6 candidates that have been very, the New York Health Act is a huge part of their they're essentially campaigning on the New York Health Act, asking to be put in office so that they can vote on this. So the technical question of how do we pass the New York Health Act, legislatively, what needs to happen is we get 1 more co-sponsor, so we have the majority in the state Senate. And then there's 2 more steps between getting that person and actually having this as the law of the land. And that is getting it to be called for a vote. So we know sometimes in American politics, one shenanigan game they like to play with us is, there'll be all the support we need to pass legislation, and then the legislative leaders just won't call it for a vote, and kind of use that, get out of making a decision by just never calling it for a vote. So we need to get another co-sponsor. Then we need to put pressure on the leadership of the state Senate and Assembly to actually bring it for a vote so it can pass. And then we need to put a ton of pressure on Governor Cuomo to sign it into law, because he is not excited about the New York Health Act. It will raise taxes on rich people who has kept him in office for the past decade. So we need to keep the energy up to get him to sign it into law. So that's the technical things to get it passed. How to help pass the New York Health Act, hopefully you're all sold by now, is for the next week, really the most strategic thing to do is to phone bank for one of these candidates. So I am from Troy, New York. I grew up right outside of Albany and Troy in the 43rd district. So for the last 2 days, I've been phone banking with Patrick Nelson. He seems like a great guy. Every call, he's we need to get the New York Health Act passed. So thank you guys so much for coming to phone bank for me. So for in the next week, the most strategic thing to do is to support these campaigns and try and get these people into office. And then essentially after November 3rd, after November 3rd, we have to see what the new strategy is, depending on how many seats if we gained or lost seats with this election. But so beyond phone banking, you can participate in social media actions. If you follow all these guys on Twitter and IG, like their posts, share them, let people know. Certainly, if you're from any of these areas, or if you have ties in Rochester, Ithaca, like around the Capital District, or in I forget what area of Long Island Christine Pellegrino district is in, but it's not too far out east. Try and, as much as we can, get the word out about these state Senate races. And I just put the Campaign for New York Health. So I work closely with the official Campaign for New York Health. So you definitely go to their website, sign up for get updates from them. Sometimes they send out updates. I try to forward important things to my listserv that you guys are all now on, but sometimes I don't always forward everything from the campaign. So get on the campaign's listserv yourself, and also the Democratic Socialists of America, particularly if you live in New York City, are doing some really great on-the-ground organizing work, and those can be good people to get involved with. Okay, so how do we improve the New York Health Act for birth workers? Really come back next week, because that's really the main topic of next week, is the nitty-gritty of the bill and where we can maybe add things or change things in the bill to improve it for birth workers. The Reproductive Futurism Conference just passed, but if you didn't go, if you weren't able to go, see if you can get access to some of the recordings. I think it's really great for us to continue to collectively imagine what giving birth in a less racist, less misogynistic society will look like. Come back next week. And so we're all on the same page for the working group. Make sure I have your make sure I have your contact information. So if you haven't filled out the form I sent in the chat box earlier, please do that. And then for folks who maybe, if this is your first time hearing or seeing me and you're interested and curious about the organizing work that I've been doing, and you're interested in getting involved more, particularly if you're a birth worker and you've been interested in I'd love to, there's this huge issue and I'd love to think of ways we can address it in a policy way. I want to work with you. I want to help connect you to other people who are thinking along the same lines so we can write those bills and get them passed. So thank you guys all so much for coming out tonight. That's really all I had to share with you. But I'll end the screen share and open the floor. What are thoughts, comments, questions, concerns? And if you need to log off, feel free. But what are you guys thinking?
You were waving to her, you want to talk?
I was.
Well, now's your chance.
Could I make a comment?
Yeah, go ahead, Fred.
We need more than one senator, even though that'll get us to a majority. If you think about a politician, Republican or Democrat, who's in a district which is balanced and they know that they will never have to vote on the Health Care Act because it won't come up because the Senate won't let it, then you might support it. And when it comes to the fact that there's enough senators to pass it, your support might waver. So we need to get more than one senator in place. That's political reality. That's how people run offices. The second and much different point is, I've been stunned by the fact that my healthcare providers, over the last couple of years, I go in for a problem at my family care practice or the ear, nose, and throat guy because couldn't hear out of my left ear. I say, do you know about the New York Health Act? They say, man, not so much, which really startles me. And so I've taken to carrying around, there's a little two-sided, one-page printout that describes the New York Health Act on the New York Health Act website. And you can hand that over and say, here's what it would cover, and here's essentially how it works. It's pretty simple. Mm-hmm. It looks like every health act you ever see if you travel throughout Europe or Singapore or Taiwan or Australia. So, but the fact that they don't know, and the more, and I think the people on this call are talking to doctors and various healthcare providers all the time. It's an opportunity to really canvass and push on that.
Yeah, absolutely. I think there's no policy element built into healthcare providers' job responsibilities. And I think, certainly as a nurse, when I first started getting involved in activism, like I thought my role was just going to be to describe what the problem was to legislators and they would come up with a solution. And I was very disappointed to learn that legislators don't actually like have the resources to like, it's not like at a state senator's office, they have 20 people on staff and 10 of them just research things to make great legislation. They have like 4 or 5 people on staff and all of them are just answering the phones and setting up meetings and doing constituent services, not really like delving into issues affecting their constituents and coming up with innovative legislative policy designs. So I think a problem that Fred really those 2 stories highlight is that like legislators, I think, often think that healthcare providers have a handle on like what policies are going to help and which ones won't. And healthcare providers think our legislators are paying attention generally to what the issues are and working to create legislation to address it. And we don't realize there's actually nobody in the middle who's helping bridge, who's helping, healthcare providers be educated on what's happening on a policy level. And, there's not a lot of people working with healthcare providers on how to translate what they experience in a clinical environment into policy. And there are not a lot of people helping legislators translate their ability to make laws and use that to address the clinical issues well. So I think I'll often sound like a broken record asking people to, asking birth workers to give me their information and saying like, what kind of things are you interested in? What kind of problems are you seeing? What kind of bills can we write? Not because I think we can write bills tomorrow, like it's going to be a process of learning how to write policy and legislation. But essentially like if individual doulas and nurses and midwives don't stop and create the policy, it's just not going to get written. So like, I think every doctor in the state of New York knows that health insurance is a pain in their butt and taking away from their ability to focus on clinical care. And, but there's no infrastructure to get to every health provider in New York and say like, oh, here are the policy solutions that you could be helping support that would address that. And so that is kind of what I think PNHP, which is the Physicians for a National Healthcare Program, I think they're kind of like the doctors who are reaching out to other doctors to do that work for them. And I think kind of the role I'm finding for myself in the birth world is to try to help birth workers realize what the potentials are for our political power, and coming together to create legislative solutions to the things that we are all too familiar, like the problems we're all too familiar with on a day-to-day basis. Were there any other like questions or things to clarify, something I said that didn't quite make sense? Well, guys, I'm so grateful that you all came and that you stuck with me. Please feel free to, you'll see, I think I mentioned before that on the form is a link to register for volunteer onboarding, which I do Wednesdays at 2. So if you're just interested in chatting more with me about like the other stuff, please, that's the best place to do it, unless you already organize with me and if you get emails every week about a weekly check-in. Come check in with me at the weekly check-in. And if you're like, ooh, yes, definitely let me start volunteering tomorrow, I have a bunch of time in the next week and want to use it on this, text me and I'm happy to like touch base with you one-on-one about how to most effectively use this next week before our next teach-in. Cool. Well, guys, thank you again so much for coming out. Have a great night, and I will see you all next week.
Thank you. Thank you.
Thank you for all your work.
Thanks a lot, Katie.
Thanks, Katie.
So.